Everybody, my name is Cindy Wojak, and today I will be going over my pregnant woman case study for my WIC rotation. So throughout this presentation, I will be using the nutrition care process model. I will first be going over the client's nutrition assessment, followed by using a couple of PES statements to go over the nutrition diagnoses, and lastly, I will go over the nutrition intervention monitoring and evaluation to go over a plan that is best fit for the client. So my client was a 20-year-old Middle Eastern woman who is married and is expecting her first child, and when we took her measurements in the anthropometrics room, she stood at a standing height of 5'1.5" and weighed at 115.9 pounds. She also mentioned that her normal pre-pregnancy weight was at 108 pounds, and she's currently at 14 weeks of gestation, or about 3 months. When I calculate her ideal body weight, it came to be at 105 pounds based on her gender and height, and so she is at 103% of her ideal body weight. When I calculate her BMI, it came to be at 20.1, which is good because it's within the normal range between 18.5 to 24.9. And so far, the amount of weight that she's gained throughout her pregnancy has been 7.9 pounds, and this is good because based on her BMI, we want the total weight gain throughout her pregnancy to be between 25 to 35 pounds. So this is a chart that kind of goes over how much weight a pregnant woman should gain based on her weeks of gestation. So according to where my client's measurements are, it'd be right about here. So she's just a little bit above the total amount of weight gain that's recommended, but she stated that her weight gain has been slow and steady, so I think that's really good. From her diet history interview, she stated that she had no food allergies or chewing or swallowing problems and that her bowel habits are normal. So she's had no diarrhea, constipation, nausea, or vomiting. And nothing has changed with her eating habits. They've all been pretty normal and pretty much the same. And she also mentioned her appetite's been really good and that she had no specific food preferences. And she did mention that she does like to eat cheese and fish and turkey lunch meat as a snack or sometimes with meals. And all of these food items can be highly susceptible to foodborne illness and contamination. So I would definitely want to educate my client on food safety just to keep her and the fetus safe. And she also mentioned that sometimes she does crave ice, and this can lead to iron deficiency anemia, and this is a form of pica known as pagophagia, so I would need to educate my client on iron deficiency anemia, and I want her to know why it's important as well. So some 24-hour recall questions I would want to ask my client is to ask what her typical eating pattern is, specifically to get an idea of what her eating schedule is like, what times does she normally eat throughout the day, what kinds of foods does she like to eat, and things like that, as well as how many meals does she eat. Specifically, does she eat breakfast, lunch, and dinner, or does she eat a couple meals a day, just to kind of see what her meal and eating patterns are normally like day to day. I would also want to ask her if she snacks often throughout the day. Does she snack in the day and at night? Does she snack one of those days, just to kind of get a general idea? And I would also want to ask her what her favorite food items are, just to kind of see if she normally likes to eat these foods all the time, or if she has any specific cravings during her pregnancy to kind of help her with that. And also I would want to ask her who does the cooking and grocery shopping at home, just to see in the household who mainly does these responsibilities and just to get a general idea as well. So my client is not on any medications, and when we measured her hemoglobin value, it was at 12.7 milligrams per deciliter, and this is considered to be within the normal range, but I also want to be careful and monitor it because of the pagophagia. So now I'm going to talk about the physiology of pregnancy. Now, mainly I'm going to talk about the hormones of pregnancy and why they're important. So estrogen is very important because it's going to provide blood flow to the uterus and the placenta. And progesterone levels are going to be high during pregnancy as well, and it's going to cause a lot of the organs and internal structures to increase in size, particularly the uterus. And progesterone also can help loosen the ligaments and the joints, which is why some women might feel back pain when they're pregnant. And oxytocin is another important hormone in pregnancy, and it's very important also for milk production, for breastfeeding an infant, but mainly it also is important to help strengthen the labor contractions during the childbirth process. There's also going to be a lot of changes in the uterus, so the uterus is going to provide a nutritive environment for the fetus to grow and develop, and the uterus will increase from the size of a pear in a non-pregnancy state to fit the size of a full-term baby at about 40 weeks of gestation. And so the tissues from inside the uterus are going to help it grow for the first 20 weeks of pregnancy, and it will start to increase from a size originally at 50 grams to 1,000. And the uterus will help to stretch to accommodate the growing baby, but also the placenta and the amniotic fluid. And the uterus will actually increase its size by about 5 times by the end of pregnancy. So the heart and the red blood cells are going to change as well. So the heart is going to increase in size when a woman is pregnant, and because of this, the resting heart rate, or the amount of heartbeats per minute, and stroke volume, or the amount of blood pumped out of the heart by one beat, is going to increase. This is going to increase cardiac output, and so this is going to increase the amount of blood that's going to flow away from the heart. And so the heart is going to work 40% harder during the pregnancy state. And so a woman who is pregnant is going to have 1.5 liters more blood. Also, pregnant women are going to have more red blood cells, but they're going to be more dilute because of the high blood plasma, and so that's why women are pregnant need a lot of iron in their diet, or higher intakes of it, to help with this as well. There's also going to be changes in blood pressure, so the muscular walls of the blood vessels are going to relax slightly, and there's going to be less resistance to the flow of blood around the body. And because there's less oxygen and blood being pumped to the brain, specifically during the first trimester of pregnancy, this is going to result in low blood pressure, and this is very common in the early pregnancy stage and can lead to dizziness. So that's why if a woman does have low blood pressure, you'd want them to stand up a little bit with support, or have them sit up with their back up, kind of having a chair or pillow behind them, because sometimes lying on the back can result in a drop in blood pressure. And also the vena cava is going to be compressed when a woman is pregnant, so the blood flow to the heart is going to be reduced as well. Also, with other changes, there's going to be shortness of breath, so the lungs are going to work 50% harder. The GI transit time is going to be slowed down, and the food that is coming through the digestive tract and into the GI walls is going to be slowed down. And it will be slowed down because the walls within the GI tract itself are going to be more relaxed. And indigestion and heartburn are very common symptoms of this when a woman is pregnant. And urine production is going to increase because the kidneys are working extremely hard to extract the waste products from the blood, and this is going to produce more urine, which is why when a woman is pregnant, she does have to urinate often. So now I'm going to talk about the stages of labor. So for stage 1, it starts off with the latent phase, and this is where the cervix is going to thin out and dilate and stretch to about 3 to 4 centimeters, and this was when the progression of labor is going to accelerate. Then this is followed by the active phase, so this is when the cervix is going to dilate more rapidly, the contractions are going to be stronger and longer as well as closer together, and so the cervix will dilate about 8 to 10 centimeters, and the contractions are going to happen every 2 to 3 minutes. And once the woman starts to feel the baby descending down into the pelvis, this is going to signal the active phase, and this will also signal the transition period, which can happen for as short as a few minutes to as long as a few hours as well. So the next stage is stage 2, and this begins when the cervix is fully dilated, and this is going to end with the birth of the infant, and this can also last from a few minutes to several hours. And so in this stage, the contractions are going to be a little further apart at the beginning, and this will come with the urge from the infant pushing down lower into the pelvis. And so with the pressure of the woman pushing and the infant moving closer down the pelvis, this will lead to the infant moving downward towards the birth canal, and then the uterus is going to relax, and then the contraction will be finally over when the baby's head will recede slightly. And so that's why when you see the baby's head or scalp being visible, this is because of the perineum will be bulging down during when a woman is pushing in this stage of labor. Finally, in stage 3, this is going to begin after birth, and it's going to end with the separation of the placenta. So the uterus will contract again after birth in this stage, and the separation of the placenta from the uterine wall is when it's going to signal in this stage. The placenta is usually pushed out from the uterine wall in about 5 to 10 minutes, and so the uterus will become very firm and contract, and these mild contractions will occur because it's going to help cut off and collapse any open blood vessels where the placenta was normally attached. And if the placenta does not leave the uterine wall, a woman can bleed profusely if the stage isn't complete. So these are just a few pictures that go over the 3 stages of labor. And now I will be talking about iron deficiency anemia. So this occurs when iron stores are too low to support red blood cell production, and this can occur by itself or with another chronic disease. And this primarily occurs when iron deficiency is severe enough to diminish erythropoiesis or red blood cell production and can lead to anemia development. And so erythropoietin is a hormone that's released by the kidneys to release or cause more red blood cells to be released, which is going to increase red blood cell production. And iron deficiency anemia, this is one of the main things that primarily occurs. And also, most iron that is absorbed in the body is derived from heme iron or animal protein. And also, excess iron is originally stored as ferritin to help protect the body from oxidative damage. And so, women who are pregnant need higher intake levels of iron because they're going to lose about 2 milligrams of iron daily during their childbearing years. And so, this is a chart that kind of goes over the metabolism of iron throughout the body. And so pretty much what's happening in this picture is that the mechanisms of the adaptation to iron deficiency are primarily centered on the suppression of the hepatic hormone hepcidin and the tissue hypoxia that develops consequent to anemia. And so you have red blood cells that are going to be recycled once they're released from kidneys, or primarily from the kidneys, and so these spleen macrophages are going to recycle them. And you also have apotransferrin, which is the molecule that is originally not bound to iron turning into transferrin, and this is very important to uptake iron to the heart and skeletal muscles and other cells on the body, such as enterocytes. And once iron deficiency anemia starts, this reduces the levels of iron in the liver. And once this occurs, it's going to increase the synthesis of the iron carrier transferrin. And so this means that the uptake of iron from the transferrin receptors to all cells and organs that needs iron primarily in the skeletal muscles and the heart is going to be reduced when iron deficiency anemia occurs. And this is a picture that just shows the symptoms of iron deficiency anemia in this picture. So now I will be going over the nutritional recommendations for my client. So I used the Harris-Benedict formula to calculate her caloric energy needs. And for the second trimester, she would need about 1,694 kcals, and in the third trimester, about 1,804. And for the DRI maintenance of protein in a pregnant woman, my client would need about 67 grams per day. So I took 0.8 grams per kilogram and I multiplied that by her body weight and added about 25 grams per day, because when a woman is pregnant, she needs this. And I got it from the Academy's Pocket Handbook to calculate the DRI adult maintenance requirements for protein. And for the fluid requirements, I found it on the Nutrition Care Manual website, and so a pregnant woman needs between 35 to 40 milliliters per kilogram of body weight to maintain the fluid requirements. And so when I calculated this, it came to 1,844 to 2,107 milliliters per day of water. And so I would want her to start off at the lower end of 1,844 and then slowly increase it just to make sure that she gets enough fluids as well throughout the day. And so I got this chart from Krause's Food Nutrition Care Process, and this goes over all of the DRIs of the micronutrients that a pregnant woman needs. And so for my PES statements, I wrote food and nutrition related knowledge deficit related to food safety and prenatal vitamins is evidenced by consuming fish and cheese, as well as currently not taking prenatal vitamins during interview. And finally, I wrote inadequate mineral intake related to iron deficiency anemia as evidenced by stating consumption of and craving ice during the interview. So for the intervention, I would want my client to go to a pregnancy group nutrition class just to see if she has any questions on nutrition related issues or concerns that she might have or might want to talk more about while she's pregnant, and also to get more of the support that she would need as well. And I would want her to go to these classes to learn more about food safety and iron deficiency anemia, because my client might possibly be at risk for this. So I'd want to make sure that she and her fetus are safe as well. I would also want to recommend specific referrals for prenatal care, because my client did mention that she's not taking prenatal vitamins at the moment. So I'd want her to get the best care for her and her fetus as well. For monitoring and evaluation, I would want to check her iron levels to keep seeing if they're in the normal range. And I would also want to take her anthropometric measurements to see that her weight gain is still going slow and steady and within the recommended amount as well. And I would want to make sure that my client, after the initial interview with following up with her, I would want to see if she's starting to take her prenatal vitamins, as well as learning a lot of information from the group nutrition classes, just to make sure that with her and her newly expected newborn baby, she can use a lot of this information to learn why nutrition is so important and to help her baby grow and develop. These are my references, and I want to thank you so much for listening to my presentation.